All right, let's take a deep dive. Today, we're exploring something incredibly common, something you see every single day, probably on, well, almost every patient.
Mm-hmm.
But understanding it properly, especially for key exams like the MSRA, is absolutely vital.
Definitely.
We're talking about melanocytic naivety, the medical term for what most of us just call a mole.
That's right. Moles are everywhere, aren't they? And look, the vast majority are completely harmless, benign growths.
Right.
But being able to identify the different types, understand why they pop up, and really importantly, recognize when one might not be benign.
Mm. Well, that's a fundamental clinical skill. And yeah, definitely high yield for your revision.
So our goal in this deep dive is basically to cut through the noise, get straight to the essential facts you need for the exam.
Exactly.
We'll unpack what a mole is, why they happen, what they look like, how to spot the difference between a typical one and something, suspicious,
Yeah.
and what to do about them, all with that MSRA prep firmly in mind. Sounds good. So let's kick things off right at the beginning. What is a melanocytic nevus?
Yeah, what's the definition?
Simply put, it's a common benign skin lesion. The key thing is it involves the proliferation of melanocytes.
Okay, melanocytes.
Mhm.
Those are the pigment cells in our skin, right? So it's like a little cluster and overgrowth of those cells.
Precisely. You can think of it as a benign neoplasm, a growth of cells containing these specific nevus cells, which are a type of melanocyte.
And where do you find these cell clusters?
They can be in different layers of the skin, usually the epidermis, the dermis, or sometimes both. Very, very rarely down in the subcutaneous tissue.
The appearance-wise, what's the general picture?
Generally small pigmented spots. They can be flat, we call those macules, or slightly raised bumps, papules, or even larger bumps, nodules.
Okay.
And you find them pretty much randomly distributed across the body, face, trunk, arms, legs, scalp even.
So they're not all identical in terms of how deep they sit in the skin. I gather there are different types based on where those cells are.
Exactly, and this classification based on depth is actually quite important. It helps understand their appearance and sort of when they tend to show up. There are three main types.
Right.
First up, the junctional melanocytic nevus. Here, the nevus cells are located right at the boundary, the junction between the epidermis and the dermis.
Okay, the dermal-epidermal junction. So they're technically in the epidermis right on that line.
Yes, right on that junction. And because they're superficial, they typically look flat, like metules, usually tan to black, quite round, generally less than a centimeter across.
Makes sense. What's next?
Then you have the compound melanocytic nevus. The name kind of gives it away. A compound suggests a mix,
Uh-huh.
and it is. These naevi have cells both at the junction and extending down into the dermis. So intraepidermal and dermal components.
Spanning both layers then, how does that change how it look?
Well, because they have cells going deeper into the dermis, they're usually raised. So think papules, sometimes small nodules. Color-wise, often brown to black, quite dome-shaped sometimes, and again, typically under a centimeter.
Got it. And the third type?
Finally, the deepest one is the dermal melanocytic nevus. Here, the nevus cells are pretty much entirely down in the dermis, intradermal, not really at the junction anymore.
So if the cells are deeper, are they still as pigmented? You mentioned pigment before.
That's a really good point. The pigment tends to be densest right where the cells are most concentrated initially, which is often at that junction.
Right.
As the cells move deeper into the dermis, the pigmentation often becomes less intense. So dermal naevi can actually range from skin color to maybe light brown.
Interesting.
Though they can still be pigmented, don't get me wrong, but they're usually raised papules or nodules, often lighter than the junctional or compound types.
Okay, so let me try that analogy. Skin is like a building.
Yep.
Junctional is on the ground floor, the junction.
Yep,
Compound is ground floor and basement, the dermis.
exactly.
And dermal is just down in the basement. And being in the basement might mean they're lighter in color?
That's a great way to think about it. And interestingly, there's often an age link too.
Oh, yeah?
Junctional and compound naivety are super common in kids and young adults. You usually see them appear before age 20.
Okay.
Dermal naivety tend to pop up a bit later, often in the third and fourth decades. So seeing a new raised, maybe skin-colored bump appear on a 40-year-old, quite often that's a dermal nevus developing.
That age pattern is actually quite useful clinically, isn't it? Helps differentiate.
It can be, yeah.
Now, speaking of why they appear, is there a single cause? Or is it, more complicated?
Well, the exact cause isn't fully nailed down. It seems to be a mix of things.
Like what?
Genetic predisposition definitely plays a role. If moles run in the family, you're more likely to have them.
So genetics loads the gun.
And UV radiation kind of pulls the trigger, that's the thinking. Excessive sun exposure, and especially having had significant sunburns, are big risk factors for developing moles.
Right, so fair skin, family history, lots of sun, sunburns, all increase your likelihood. And the basic process, the pathophysiology, is just that proliferation of melanocytes, maybe kicked off by that UV.
That's the current understanding, yes. The melanocytes multiply, cluster together, and form the Naevus.
Just how common are we talking here? I mean, does pretty much everyone have moles?
Pretty much, yeah. They're extremely common. Those people have multiple Melanocytic Naevus.
Right.
Exact prevalence figures for the UK, for instance, aren't always easy to pin down in the literature, but just look around, they're everywhere.
Okay, fair enough. Let's switch gears then to the clinical side. You're in clinic, you see a spot. What are you looking for? What are the typical features of a benign mole?
Typically, they're well-defined. Clear borders.
Okay.
They can be flat or raised, like we talked about with the types, and obviously they're pigmented tan, brown, black, that sort of range.
A diagnosis is usually just by looking.
For the vast majority, yes. It's a clinical diagnosis based on inspection. It's also good practice to ask if it's always been there congenital or if it came up later acquired. Sometimes that history is useful.
Do they cause symptoms? Like, are they ever itchy or sore?
Most of the time, completely asymptomatic. You don't even know they're there.
Right.
However, they can change, grow, alter shape, size, color, and they can become symptomatic, maybe itchy, painful, irritated, even bleed, especially if they get rubbed or caught on clothing.
Okay.
But sometimes symptoms can start without any obvious trauma, and that can be a bit of a red flag.
And the signs we look for are basically that pigmentation and the shape round, raised, dome-like, flat.
Exactly, depending on the type.
Okay, this is where it gets really crucial, especially for exams.
Yeah.
You see a pigmented spot. How do you know it's not just a harmless mole? What else is on the list? The differential diagnosis.
Absolutely vital. Telling a benign mole apart from other things, especially malignant things, is core stuff. So your differential for a pigmented lesion needs to include a few key players.
Let's listen.
Okay, definitely dysplastic Naevus. Sometimes called atypical moles. They often look a bit irregular, a bit off compared to a standard mole, usually benign, but they do signal an increased melanoma risk.
Right, the funny-looking ones.
Exactly. Then melanoma, the big one you absolutely must rule out. Skin cancer from melanocytes can arise in an old mole or appear brand new.
Right.
Spitz Naevus. Less common, often in kids or young adults. They can look worryingly like melanoma sometimes, both clinically and even under the microscope. Bit of a diagnostic curveball.
Tricky way.
And seborrheic keratosis. Very common, benign, especially in older adults. Often look waxy, kind of stuck on. But they can be dark brown or black, and if they get irritated, they can mimic other things.
So, thinking about an MSRA question, maybe a vignette, 55-year-old pigmented lesion on the back?
You need that list of differentials ready.
Spot on. And
Yeah.
the vignette might give you clues, age points towards seborrheic keratosis, maybe. Irregular features point towards dysplastic Naevus or melanoma. Location, history.
Yeah, puts it all together.
Yeah.
So this leads perfectly into investigations. If diagnosis is usually just by looking, when do you need to do more? When do investigations come in? Right. Investigations are really for when you're suspicious. Suspicious of melanoma or maybe a very atypical nevus that you can't quite reassure yourself about just by looking.
And there's a pathway for that.
Yes, the sources lay out a pretty clear pathway. First line, if you're unsure after your clinical look, is dermoscopy.
That special magnifying light thing.
Exactly. Also called epiluminescence microscopy. It lets you see structures and patterns under the skin surface, stuff hidden from the naked eye. It's incredibly helpful for distinguishing benign from suspicious lesions.
So if you have access to dermoscopy, that's your first step for anything worrying.
Definitely the go-to tool for assessment. Now, what if the dermoscopy is still, well, indeterminate? You look, you see the patterns, but you're still not 100% sure if it's benign or something nasty.
What then?
Then the next step is to consider an excision biopsy, usually with narrow margins initially. This is especially true if your clinical suspicion for melanoma remains high, even after dermoscopy.
And that biopsy does two jobs, right? It diagnoses it, send it to histology, and it could be treatment too, if it is an early melanoma and you get it all out.
Correct. It gives you the definitive answer.
Okay. So if most moles are benign, do we actually need to treat them? What's the general management plan?
For the vast, vast majority of simple, benign naive, no treatment needed. Leave them alone.
Right.
The key general advice is about monitoring, regular self-examination by the patient, and being aware of any changes.
How do you monitor effectively? What specific changes should people look for, or what should we be looking for or asking about?
This is where that absolutely critical mnemonic comes in the ABCDE rule. It's your checklist for assessing pigmented lesions, specifically looking for features that might suggest melanoma. High-yield stuff for any exam question on this.
Okay, let's break down the ABCDEs.
Right. A is for asymmetry. Benign moles are usually symmetrical. Draw a line through the middle. Both halves look similar. Melanomas, often lopsided, asymmetrical.
Got it. B.
B is for border. Benign moles typically have smooth, regular, well-defined borders. Suspicious lesions often have irregular, notched, scalloped, or blurred edges. C.
C is for color. Benign moles usually have one uniform color. Melanomas often show variegation, multiple colors or shades.
Yeah.
Think different browns, black, maybe even bits of red, white, or blue. Mottled appearance.
Okay.
D. D is for diameter. Generally, larger lesions are more concerning. The classic cutoff, often quoted, is 6 millimeters, but really, it's about size relative to other moles, and especially if it's growing larger.
And E.
E is for elevation and evolving. Our source specifically mentions elevation is present and irregular. Also, crucially, evolving, meaning the lesion is changing over time. Change in size, shape, color, symptoms, anything different is a major red flag.
Right. So a classic MSRA scenario describes a mole with an irregular border, maybe two different colors, and asks, what's the next step? Recognizing those B and C features immediately tells you, high suspicion needs further action.
Exactly. Those features shout, this isn't just a simple mole. Time for dermoscopy or potentially referral for biopsy.
So if a mole does need removing, either because it's suspicious or maybe for cosmetic reasons, what are the options? Well, if there's any suspicion of malignancy, the standard is an excision biopsy. You cut it out completely, usually with a small margin of normal skin, and send the whole thing for histology.
Makes sense. Get diagnosis.
For lesions in trippy spots, like the face, referral to a specialist dermatologist or plastic surgeon is often best. For cosmetic results and, frankly, medico-legal reasons too.
Okay. Any other removal methods?
Shave and cautery is sometimes used, done under local. You basically shave the lesion off level with the skin surface, then use heat to stop the bleeding.
When would you use that?
It can give a good cosmetic result sometimes, maybe better than an excision scar for certain raised lesions. But, and this is key, it's generally only for things you're very confident are benign. You don't get the full depth for histology, so not ideal if you suspect melanoma.
Right. So when would you say removal is definitely indicated, apart from obvious ABCDE red flags? Are there specific situations?
Yeah, there are definite indications for removal, usually for histological diagnosis. These include lesions in hard-to-monitor sites, scalp inside the mouth, anogenital area. Makes sense, right? Hard to keep an eye on them.
Yeah.
Rapid growth, big warning sign. Variegated color, irregular border, those ABC features again. Any erosion or ulceration on the lesion, especially if there wasn't major trauma. New or persistent symptoms like itching, pain, or bleeding without a clear cause.
Okay.
And of course, if dermoscopy findings are suggestive of melanoma or maybe a dysplastic nevus.
So basically, if there's any real doubt, if there's a question mark over it, excise it. Get the histology.
That's the safe approach when malignancy is on the differential. Excision gives you the answer and can be the treatment too.
What about the overall outlook? Prognosis, if someone just has moles, are they okay?
The prognosis for the melanocytic naevus themselves is excellent. They are benign. Most people have them their whole lives. No problem at all.
But there's always a but, isn't there? Having moles does affect risk for other things.
It does. That's the key link. Having a large number of moles or having atypical or dysplastic moles significantly increases your lifetime risk of developing malignant melanoma.
Ah, okay. So the moles themselves aren't the issue, usually. But having lots of them is a marker for higher melanoma risk overall, either developing a mole or de novo elsewhere.
It's a risk factor.
Are there any other complications from moles themselves, apart from that big worry about malignant change?
Not really. In terms of the mole itself causing systemic problems, they might get irritated, catch on things, bleed if traumatized. But the main complication or the event that needs urgent attention is when they change.
Right.
Those changes we talked about, size, shape, color, new symptoms like itch, bleeding, crusting, ulceration. That's not really a complication of the mole, but a potential sign of complications, specifically malignant transformation. And that needs checking out fast. So yeah, wrapping up, most of these are incredibly common, totally harmless. They'll stay that way. But understanding what they normally look like, knowing the risk factors, and crucially, being super vigilant for those signs of change, the ABCDEs, new symptoms, that's absolutely key. It's that potential for change in some lesions that demands our attention and makes this such important revision.
That perfectly wraps up our deep dive into melanocytic naivety. Hopefully that's given you a really clear, high-yield overview, hitting all the key points for your MSRA revision.
Yeah, just keep those core things in mind, the different types based on depth, the risk factors, definitely the differentials like melanoma and seborrheic keratosis, the investigation pathway clinical look, then dermoscopy, then consider excision.
And nail down that ABCDE rule.
Absolutely. Master the ABCDEs. That's your practical tool for assessment.
We really hope that helps, and we wish you the very best with your studies.
For more free MSRA revision resources, you can visit freemsri.com, and for the full premium revision toolkit, head over to passthemsra.com.